Hi, I'm Dr. Michael Klein, and I'd like to thank you for joining us on Dental XP. Computer guidance is rapidly gaining acceptance in the field of implant dentistry. There are probably more than a half a dozen companies currently producing computer guidance systems. As a matter of fact, in a recent study from the Millennium Research Group, it showed that in 2007 there were more than 200,000 implants placed using computer-generated guides, and they anticipate that that number will triple over the next 5 years. However, some of you that have gone and used computer guidance have found that the results haven't always been exactly what you've anticipated. So to predictably gain the benefits of computer guidance in implant dentistry, we need to understand how the process works from scanning, through processing, planning, guide fabrication, and how to effectively clinically implement the procedure. And so what I'd like to discuss with you this afternoon, or morning as it may be, are what I call errors and opportunities within computer guidance. And these are in the areas of image acquisition, data processing, diagnosis, planning, and clinical implementation. So in the areas of image acquisition, let's first talk about the CT machine itself. That's what gathers the data. And we'll discuss the field of view in image acquisition, as well as image quality. In image acquisition, we have two types of machines that are currently being used. There's the conventional medical CT machines, which most of us are familiar with, and more recently, cone beam technology, which many of us currently have in our offices. Now, here are some of the differences. With a medical machine, we can scan and treat and utilize for computer guidance all patients. While cone beam technology, we can have some difficulty with the heavy, obese, or humpback patients. Medical machines are going to produce greater radiation versus the cone beam machine, which produces less radiation. Recent study shows that the absorbed dose from cone beam technology is somewhere between 1% to 25% of the dose absorbed from a conventional medical CT scanner. So there can be a significant less radiation dose or exposure to our patients by using cone beam technology. With the medical machine, we have to send the patient usually to a distant radiology site. While cone beam technology, we have easy access. Again, it might be within our own office or referring the patient to another dental environment to have the scan taken. Medical machines, the patients lay down, while cone beam technology, generally they're sitting. The significance being that while the patient lays down, those patients that are difficult to scan with cone beam technology can be scanned. So the patients that are heavy, obese, humpback, we can gain those images. We may have difficulty with cone beam technology. And the medical machine occupies a large footprint, while cone beam generally is suited for the dental environment, and most machines have a small footprint. Now, in the area of field of view, some machines that are being produced today have a limited field of view, some of the newer machines that are lower in cost. But when we go ahead and we limit our field of view, sometimes we can have a more difficult procedure of diagnosing that patient. So we have to be careful of those machines, where they're appropriate to use or not. And so we see here, if we expand our field of view or expand what we're able to see, we have a more diagnostic image. We also have to make sure that anything that we need to see in the picture, which is not only necessarily anatomically the bone that we need to view, but it potentially is the radiographic markers, fiducial markers for technology that's dependent upon that, also needs to be able to be incorporated within the field of view from that machine. Field of view also references the number of slices that are actually taken. When we take the CT data, we get DICOM data in the form of axial or horizontal slices. And again, we can control when we take the scan what our field of view is and how many slices or how much anatomy is actually within our area. And anatomically, then what we see is going to be impacted by what's incorporated or taken from the scan. Now, image quality is most commonly affected by movement of our patient while the scan is being taken. So what causes that movement, right? Well, most commonly it's the rotation of the patient's head, or actually it's the patient's head following the rotation of the machine causing that movement. So once the scan is being taken, we need to ensure that those images are of accurate quality. So how do we do that? We take the scan. Once the scan is taken, we review or page through all the axial images, right? And we look for what I would call shadowing of the cortical plates. And so when we see the shadowing of those cortical plates, we know the patient moves. Now, when the patient's moved and we have this shadowing, the image may be undiagnostic, or even if we can analyze what we need to see, it becomes unusable information of computer-generated guides. So if we see that shadowing, we need to rescan the patient. That's why the images need to be reviewed immediately following the scanning of the patient. And we rescan the patient to ensure that we have clear linear lines. After we review the axial images or the horizontal images, we then can review the cross-sectional images in the same manner. And again, we look for shadowing or doubling of the image of the cortical plates. And so when we see that shadowing, right, we know that the patient's moved. The scan becomes unusable for the information of computer guidance within implant surgery, and we need to rescan that patient and ensure that there's no movement of the patient. Next area is the area of processing, a critical area in having good image quality and good images for computer guidance. So when we scan a patient and we process the data, we don't have to process all the data that's been taken from that image. So here's what it affects. It affects the size of the images, as well as getting rid of the unnecessary slices will allow us to eliminate scatter or distortion artifact that we may have within our images. And so let's talk about sizing of images. When we look at this scan where the whole head is scanned, we have a full CT scan where we wanted to scan both the mandible and maxilla. If we scan that patient and we use all the data or all the images that were taken and process all those images, we find that, look at our cross-sectional image. It becomes relatively undiagnostic or difficult to use, as opposed to eliminating all the necessary images, or when we scan both our arches, process each arch independently, and then we get a more clear, defined, easier cross-sectional to go ahead and work with. We would then want to also eliminate images to eliminate scatter. So again, by eliminating unnecessary images or images that have scatter within them, we produce a much more diagnostic image. So here you see an image or a cross-section which has crown and bridge of both mandible and maxilla. And as we eliminate each section of scatter, we see we get an easier to interpret image. So it's the same image data that's in there. We're looking at the same anatomy. We haven't affected that. But we get a cleaner image by eliminating the distortion artifact or the slices that have the artifact within them. Next, we want to address drawing of the curve for processing. When the image is actually taken, we get this horizontal axial image. What we then do is we draw a curve around the arch. The significance of the curve that we draw for processing is that all the other images, the cross-sectional images as well as the panoramic images, are reformatted in reference to it. The panoramic images are reformatted parallel to that line, and the cross-sectional images are reformatted perpendicular to that line. So when we look at this, let's call it tortuous curve that's been drawn, the impact of this is that this implant that's placed in that cross-sectional image is placed in the orientation of the curve or perpendicular to the curve that's been drawn. And so let's look at implant number 19. We see the blue line, right? That's the orientation of the cross-sectional image where this implant number 19 is being placed. And now let's look at image number 20, or cross-sectional image number 20. And we see that the cross-sectional image for number 20 and the cross-sectional image number 19 almost converge on each other. Well, here's what happens. When we rotate the implant within that cross-sectional image, it will rotate in that path and plane. So what does that mean? That means when we rotate them the same number of degrees, let's call it buccally, they're actually going to converge on each other while we think we're rotating them, parallel to each other. So how do we draw a curve? Well, we go ahead and we draw a curve so that we use, usually 5 to 7 dots in the mandible. We use about 7 to 9 dots in the maxilla. We try to make a linear curve that somewhat parallels the general orientation of the mandible and our maxilla. Once we've done that, we go and we page through all the axial images so we can see what the impact of the position of that curve is relative to the buccolingual cortical plates. But we don't want to parallel those images exactly. We want to have a smooth curve. And in that way, we capture images or process the data in a way that becomes most diagnostic for our planning. So if we look at this case over here, we'll see that this practitioner went ahead and made an effort. Actually, it was me doing it for a demonstration for the video. We exactly tried to parallel the buccolingual cortical plates, which sounds like what you'd want to do, right? That way we get cross-sectional images that are perpendicular to those buccolingual cortical plates, but we get images that are difficult to utilize and difficult to interpret. Because here's what happens in this case. We see that at each position or each point of each of these cross-sectional images, the path of that processing curve is at a different orientation, and although it's parallel to the buccal cortical plates, it will cause the cross-sectional images to actually converge on each other. Next issue with processing when we draw the curve is we need to make sure that we don't just incorporate the area of interest to us. It becomes difficult to look at a diagnostic image and diagnose from this particular image over here. What we want to do is we want to extend that curve all the way through the anatomy. So in the mandible or in the maxilla, we want to start beyond the most posterior aspect of that mandible and or maxilla and begin our curve from there. And then even though we've included extra information, the images become more diagnostic. In terms of diagnosis, here's what we have to remember, something that's become critical, is a lot of us are taking these images within our office, and we have a certain legal responsibility relative to this data, meaning that we're responsible for what's going on in this image, even if it's not in the image that we process. So we're responsible to review all the information, identify the potential for pathology or other problems that are within the images, not for what we process, because remember, we may eliminate some data, but for all the data that we actually acquire. So we need to go ahead and review the information not after processing. We need to review the information after image acquisition, prior to processing for this indication. We need to also make sure that we make the most diagnostic images possible, which means scanning patients with scan appliances, with full barium teeth. We get the best three-dimensional reconstructions that way, and again, we get the most diagnostic images. Next, planning. Well, when we're using computer guidance, ideally, we're using this so we're not making any decisions at the time of surgery, because we may drill just our pilot osteotomy. We may use systems that allow us to sequentially enlarge our osteotomies, guiding each of our burrs, and possibly even implant placement. So we need to go ahead and do a lot of potential planning for this. But we have to also understand that we can't always do that. Sometimes we're going to find images that have scatter and metal artifact caused by crowns or adjacent metallic restorations. And although we may look at our alveolus and be able to accurately interpret that, when it comes to where this tooth really ends or where the alveolus really starts, that becomes difficult to interpret. And so we may want to use a system that allows us to make changes at the time of surgery, so that we can go ahead and have our general guidance from that position, but we can make some final decisions at the surgical site. Or it may be that we're dealing with a case such as an extraction and immediate implant placement, right? And where's our difficulty there? Well, where exactly is the cervical position of that implant going to be? When we look at the density of the bone, cortical bone, that overlies that root, because that bone is very thin, we can't always identify exactly where the bone ends, right, and where that tooth begins. And so we may be able to plan for our location and angle and general depth, but that final decision-making of exactly where the cervical position or portion of that tooth needs to be done at the time of surgery. How about immediate provisionalization? Well, we can plan for immediate provisionalization, but ultimately, the final decision-making, whether or not we can immediately load or provisionalize that implant, it's going to be based upon implant stability. So just because we planned it on the CT and done all our homework doesn't mean we can always definitively follow through that plan. We can't just do the procedure blindly. We still have to use good surgical technique and protocols. Now remember, when we're doing our planning, the cross-sectional images will cross the path of the processing image, of the processing line, which also represents the panoramic curve, okay, perpendicular to that orientation. So when we're in the posterior areas of both the mandible and maxilla, we can draw those lines relatively straight, and we can have images or cross-sectional images that are parallel to each other, and when we rotate our implants, they're going to rotate within the same plane and or path. When we come around the anterior mandible and maxilla, just by nature of the curve of that arch, what we're going to find is we can't do that. So let's take a look at this particular patient over here, and take a look at as we cross that panoramic curve or that processing curve, we see that the path and orientation of the cross-sectional image, as represented by that blue line, takes a different orientation. So what's the significance of that going to be? Well, if we go now and we rotate, we put each of these implants in parallel to each other, but now we rotate each one of those implants, and we rotate each one of those implants the same number of degrees buccally, what we're going to find is that when we look at those in a three-dimensional reconstruction, the implants actually become divergent. They become divergent. Why? Because when I rotate implant number 8 buccally, it rotates in this orientation. and when I rotate implant number 9 buccally, it rotates in that orientation. I've rotated them both the same number of degrees. However, they're rotating in a different path and orientation. And we can't necessarily see that just by looking at the conventional CT images. So we need to go in to be able to go into our software and understand how to manipulate the implant forms, whether they be in the three-dimensional images or in our other panoramic or axial images, to give ourselves the correct orientation, thereby producing parallel implants, or implants that are in the ideal position for the type of restoration we want to perform for our patient. Now, there are other considerations, anatomical considerations, when we're clinically using these types of systems. What if we're going ahead and placing an implant into an area where we're encountering an incline or it's a narrow ridge? Remember, there's the possibility, although these systems are somewhat rigid, for that implant deflecting off that palatal incline or that incline of bone and then traversing, it could be a half a millimeter. And that may not sound like a small amount, but we know that with implant dentistry, a half a millimeter can make all the difference in the world, whether it be for aesthetic positioning or positioning the implant within bone. So again, we can't do these procedures blindly. We need to understand where we're drilling as we're drilling, and so that we may need to look at a procedure like this, that after we've gone ahead and created our pilot osteotomy, we may need to go ahead and look at and see what the position is, decide if we want to maintain that position or modify that position, or as we're drilling this, understand that there's the possibility of that burr skipping when drilling through a system, and so we need to orient our burr and be conscious to keep the burr on path. We need to also make sure that we plan not just anatomically, but prosthetically. If we go ahead and we look at this anterior mandible, we see that if we just look at it from a purely anatomical or surgical perspective, here's where we place our implant. We bisect the buccolingual cortical plates of bone, while our tooth position is relatively dramatically different. And so we need to make sure we have those prosthetic markers. Remember, our systems are relatively rigid. We don't want to make this decision or change, which may be obvious at the time of surgery. We want to make this change at the time of planning to be able to go ahead and accurately or appropriately use these systems at the time of surgery. There's a lot of decision we make at the time of surgery that's somewhat intuitive. We don't even realize all the information we have processing in our head when we go ahead and plan our surgery and perform our surgeries. We need to take all that intuitive decision making and put it into the planning, as opposed to correcting our plan at the time of surgery. And that's appropriate relative whether it's the anterior mandibular maxilla or the posterior mandibular maxilla. The same rules apply. Now, when we talk again about anatomical planning versus prosthetic planning, sometimes when we look at our surgical guides after they've been fabricated, we'll look at, generally most of us, will look at the occlusal surface of that guide and we look for the position and placement of our implant. Is our implant coming through the occlusal surface of that tooth? Well, the occlusal surface of the tooth really isn't the determinant of what the aesthetic position of that implant is. Rather, it's the cervical position of that implant as it emerges through the soft tissue that's going to determine the aesthetic value or the potential possibilities of aesthetic value of that tooth. So it's really the underside of the surgical guide that you should be looking at in terms of proper positioning of your implant, as opposed to the occlusal surface of our guides. With these systems, our burr systems generally start to become very long. Okay, we have the length of bone that the burr has to go in. We have the soft tissue that the burr has to pass through. We have the length of the surgical sleeve that's within our surgical guide that it has to pass through. So our burrs within these systems are 17, 21, 24, 28, maybe even 30 millimeters long. So we need to go ahead and anticipate, can the patient open wide enough to be able to go ahead and place these burrs through these systems? And then there are strategies to overcome some of these difficulties, whether it's placing the burr into the surgical guide before you put it inside the patient's mouth, although that can be somewhat difficult. Having the patient close before you go ahead and place this burr to have the muscles relax so they can open wider. Or sometimes we just need to use a shorter burr, pilot the osteotomy to give us location and angle, and drill to final depth without the surgical guide in place. But again, we should be evaluating our patients prior to going ahead and fabricating these types of guides to see if they will actually be usable within our patients. We have to make considerations relative to the instrumentation that's going to be used at the time of implant surgery with computer guidance. So what's going to be the proximity relative to adjacent teeth? So it's not the size of the implant here that's taken into consideration. Obviously, that's an important consideration in planning, but we also have to plan relative to the componentry that will be involved in the placement of these implants through computer guidance or drilling through computer guidance. So the way that I'll go ahead and do this is not just plan and position my implants, but then I'll place an abutment system on top of the implant that will mimic not the dimensions of the abutment, but will mimic the dimensions of the component, surgical component that will be within the surgical guide, and see if that imposes on adjacent teeth or imposes on, the implant-to-implant relationships. Because it may also dictate, relative to the aesthetic positioning and sizing of the teeth, that we use a surgical guidance system that allows for the appropriate sizing and dimension for due to the surgical limitations of that particular case. And so here's a case where we're placing 3 implants in the anterior mandible. There is adequate space for the implant placement. But if we come to the level now of the surgical component system, we see that the surgical component systems actually overlap on each other. So there's not a limitation due to implant size, but there's a limitation for surgical guidance because of simply the dimensions that the component systems occupy within the surgical guides. And so we have guidance systems that allow for smaller dimensions. Here's a guidance system from VIP, BioHorizons, that allows only a pilot sleeve to be placed, and therefore has a much smaller dimension that can be placed even in narrow dimensions. Other limitations may have to do with significant atrophy. Long teeth may also limit the placement and positioning of instrumentation within the patient's mouth. Flapless surgery is a significant indication for computer guidance, right? We can go ahead and place our implants without having to reflect the soft tissue because we know anatomically what's occurring underneath the soft tissue. However, most of the time, or many times, we can't perform computer guidance with flapless surgery, not because of implant position, because of other things that we need to do. We may need to access the bone to do a bone graft. We may want to go ahead and reposition the soft tissue. And we may want to reposition the soft tissue because we may want to bulk out the soft tissue. It's being supported by the healing abutments on top of the implants. Or we may try to go and manage and preserve keratinized tissue, which is going to be a very common occurrence. If we were just to go ahead and drill blindly through the soft tissue, we would end up with alveolar mucosa surrounding our implants. Or we may want to come back and do a soft tissue graft at the time of implant placement, again, necessitating going ahead and reflecting a flap as opposed to doing flapless surgery. We may need to recontour bone. Here's a patient who's congenitally missing a maxillary lateral incisor, and frequently we need to recontour that bone to develop the proper parabolic architecture of bone to appropriately position our implant to get an aesthetic restoration. Now, there's going to be relative accuracy of computer guidance that has to do with the distance that the burr comes out of the sleeve until it encounters bone. So if the soft tissue is very thick, or more commonly, if we're going to extract a tooth and then place an implant, it could be 10, 12, or even 15 millimeters from the position where the drill emerges through the drill sleeve until it encounters bone. As that distance increases, right, the ability of that burr to waver or change position slightly increases. So we need to take that into consideration when we're treating these types of cases. Guide stabilization is critical when drilling with computer guidance. The implant positioning with the guide is only going to be as accurate as the stability of the guide. When we have adjacent teeth to support the guide can very predictably be stable. When the patient is edentulous or has inadequate teeth for guide stabilization, then we need to employ systems or use guides that can be secured either on the soft tissue or within the bone. We also have systems that have instrumentation that can potentially destabilize the guide. Many of the guidance systems use long-handled wrenches that hold on to the sleeves, and we have to remember that although they may be there for ease of going ahead and taking that sleeve and placing it from one implant site to the other, there's also a very long lever arm that can be imposed on this guide from that sleeve. And so we need to be conscious that we can alter the position and destabilize that guide from this type of instrumentation. So we have to be careful not to allow that to happen. And we have different guide systems. Some systems are more amenable to being soft tissue borne, some bone borne, some tooth borne. And again, it's not one tool to fix every situation. We may want to employ different types of systems for different scenarios. Now, there are some newer things that we can go ahead and do. One of the techniques that I employ is using computer guidance to go ahead and do the sinus osteotome technique. And how do I use that? I simplify the technique by going ahead and doing my planning where I position my implant just to the floor of the sinus. Then I form a guide is formed that will reflect that. I'm able to drill just to the floor of the sinus, weakening the floor of the sinus. And then I actually use the guide itself to guide not only my burrs, but the osteotomes itself. And then I can very quickly and predictably go ahead and perform the procedure of osteotoming the floor of the sinus. advancing my bone, and going ahead and positioning and placing my implants. It turns a longer procedure into perhaps a total of a 10-minute procedure, very predictably. We can also use it for osteotomes to expand the ridge. The same way, we can do this minimally invasively without having to go ahead and reflect the soft tissue off the buccal aspect of the bone. Here I'm just demonstrating the accuracy of this type of system, where we can go now and use our osteotome or use our surgical guidance to initially position our pilot osteotomy, and then we can very quickly and simply go ahead and expand the bone using our osteotomes. And again, we can also guide these osteotomes, just like the sinus osteotome type of technique for ridge expansion. We can go ahead and guide our osteotomes with our surgical guidance systems. Now, if we have proper site preparation, then we can go and come back and do and simplify the technique of flapless surgery. We do all our planning very carefully. We know exactly where the position of our bone is, how much bone we have, and we don't need to examine and look at the bone to appropriately position our implant. We do minimal soft tissue manipulation and have a very safe, effective, and fast and predictable procedure for our patients. And that's whether we're going through the soft tissue or dealing with an immediate extraction site. We even have some systems that allow the soft tissue trephines to additionally be guided through these guidance systems. And so different systems have different tools and techniques, and I think over time we're going to see more and more tools developed for computer guidance systems. Now, immediate provisionalization, when we make that determination that it's appropriate for that particular case to go ahead and load those implants, it's ideal to do with computer guidance. It takes a relatively lengthy procedure and turns it into a very efficient and fast, procedure. There are technologies that employ the ability to go ahead and do final restoration as opposed to just immediate provisionalization. We have to be very careful with this because, again, the final determination of whether or not the implants can be loaded is going to be made at the time of implant placement and can't always be done just by going ahead and looking at the CT images. So sometimes we can't do the final definitive restoration. Sometimes we may even make the decision at the time of surgery that that implant or particular implants should not be immediately loaded or provisionalized due to the limited implant stability that is in that areas. But ultimately, the determination of whether that immediate provisionalization is going to be successful and can be done is not going to be computer guidance, but it will be patient selection, it'll be planning of the procedure, and how we clinically implement the procedure, at that time. We can simplify existing techniques with computer guidance. So we have many areas where it's difficult to access scenarios. We can have a patient who's missing mandibular posterior teeth, a fair amount of posterior ridge atrophy, and it becomes very difficult to access and visualize these areas, especially if they have a limited opening. And so we can go ahead and we can use computer guidance that will allow us to go ahead and perform our procedures in a relatively blind manner. So we all have those patients who, again, have those difficult scenarios. They may have limited opening, right? Limited opening can be challenging to go ahead and employ some of the tools that we use. But again, limiting opening, even with conventional tools, can be somewhat difficult for us to access and see what we need to see. And computer guidance allows us in those scenarios to have a little more, and I hate to use the word blind procedure because nothing should be done blindly, but we can do it a little bit more blindly using computer guidance. And how about that patient that won't allow us to sit them back, where we have to stand on our head to get to certain areas to go ahead and perform our procedure? With computer guidance, again, it goes ahead and it's an aid to us clinically at that time to go ahead and perform our procedures by guiding us without having to stand on our heads to go ahead and access and visualize what we need to see. Another more significant area that's becoming more and more common, at least in my practice, is the management and treatment of elderly patients. And with computer guidance, what we can do is we can limit the surgical intervention we have. There are many procedures that we can perform on a patient, but it might just take too long, and the patient may not be able to tolerate the length of the procedure. So using computer guidance, we make the procedure shorter, quicker, more efficient, and all of a sudden we can employ a lot of procedures and techniques for that patient simply by shortening the length of time that it takes us to do that procedure. We also have many patients that are today on anticoagulant therapy. And so by limiting the surgical intervention that we have, we can now go ahead and provide implant therapy for them, where before we may have been concerned about the bleeding that may be involved because of the limitation of taking the patients off that anticoagulant therapy. But even with all this, surgically, we have to understand what anatomically is going on. We can't do this completely blindly. And computer guidance is not a substitute for good surgical technique, but it requires a thorough understanding of computer guidance technology, anatomy, surgical technique, hard and soft tissue healing, implant biomechanics, and prosthesis design. And only then it becomes an effective and predictable tool and technique in implant therapy. I'd like to thank you for joining me today on Dental XP, and I'd like to thank Dental XP for inviting me to participate in their forum.